the co-host. Meeting call to order. Rotarian Ruby Agarwal is not available as she's on mute. Okay, so
I request the Rotarian President Ritika Gupta to confirm the minutes of the previous meeting.
So the minutes of the previous meeting were circulated on the group and no queries have been raised for the same. Thereby the minutes of the previous meeting stand confirmed. Thank you very much.
Now,
and moving on.
Please close
Yes.
this PPT
Yes.
presentation. Please close it now.
Yes, we can view it. Please close. I would now request our charter and founder president, Rotarian Lal Goel, to make an announcement. He has an announcement to make.
Today, with a heavy heart, I have to inform all our members that our charter member, Rotarian Ashok Kumar Gaur, lost his battle with liver cancer and left us on 19th September. With heavy hearts, we mourn the loss of our beloved Rotarian Ashok Kumar Gaur, a charter member of the Rotary Club of Organ Donation International. His passing leaves a void in our Rotary family and in the hearts of all who knew him. From our club's inception, Rotarian Ashok Kumar Gaur stood as a beacon of service above self. His legacy of service, compassion, and cheerful spirit will continue to guide us in our endeavors. The laughter he brought to our gatherings will be cherished memories that we will carry forward. His life was a testament to the Rotary ideals of fellowship, service, and making a positive difference in the world. As we bid farewell to our dear friend and fellow Rotarian, we take comfort in knowing that his spirit of service and the joy he brought to our lives will live on through the countless lives he touched and the causes he championed. Our thoughts and prayers are with his family during this difficult time. May they find strength in knowing that Rotarian Ashok Kumar Gaur's legacy of kindness, service, and fellowship will continue to inspire generations of Rotarians. Rest in peace, dear Rotarian Ashok Kumar Gaur. Your service to humanity and your friendship will never be forgotten. With deepest condolences, now we will observe 1 minute silence. Thank you.
Taking the meeting forward. So we have with us a very esteemed guest, Dr. Pushkar Mehta. I would now like to take the opportunity of sharing his brief introduction with you. So Dr. Pushkar Mehta is an MBBS, MBA from IIM Calcutta, and he's an accomplished healthcare leader currently serving as a medical superintendent at Nanavati Max Hospital, Mumbai. With extensive experience in healthcare management and operations, he has previously held the position of principal consultant at PwC, PricewaterhouseCoopers, India, and served as a head of medical operations at Gleneagles Hospital, Mumbai. So this is the brief introduction that we have of Sir, and I would now like to pass on the discussion to him. I invite him to take forward the conversation today, sharing with us the topic at hand. Role of corporate hospitals in organ donation.
Oh, thank you for the brief introduction. I hope I'm audible.
Yes, please. Go ahead.
Yes.
So an interesting topic. I've had the privilege of presenting this topic only a couple of times till date. Thank you for giving the opportunity to present it here. Apart from the brief introduction, this topic remains very close to me. I have roughly 350 plus transplants experience. I have experience in pancreas, simultaneous kidney pancreas, hand transplants. There are few to specify because they are apart from liver and kidney, which are more routine in India. We've also done a bone transplant, have been privy to that, apart from heart and lung. As of today in India, all the active organ licenses that have ever been issued, I have got an opportunity to actively be a part of all these organ donations. The role of corporate hospitals, and I would interpret corporate hospitals as tertiary care hospitals, hospitals which have all services under one roof, professionally managed and more organized as a group of hospitals. And these group of hospitals and the role that they have to play in organ donation. We move ahead. I'm aware and I have been given a brief that the audience here is well informed of the processes as well as the act and how organ donation happens. I just wanted to interpret a couple of clauses in the overall act, my experience of about more than a decade in organ transplant and a voluminous number of organs. Which organs can be donated? I think this is one of the questions that always keeps coming up. Can we include a new organ? Can we do so? As I said, we have done a hand transplant. I have experience of 3 hand transplants. So a natural question come: can we do a leg transplant in that case? So when can you really do an organ transplant? The explanation is that the act in India suggests that if a particular organ is removed completely from the body, it should not regrow. And if it does not regrow, it can be transplanted only and only for therapeutic purposes. We cannot do an organ transplant for diagnostic purposes. We cannot do an organ transplant for academic purposes as well. This is only strictly human to human organ transplant in the act. So any other type of transplant, xeno, etc., are not governed under the act, and as of today stand illegal in India. I'm audible, right? I can continue.
Yeah. Please go ahead.
Yes, you are audible.
India has been a benchmark in the overall transplantation journey. Right from early 90s, we have had an act that governs. We have NOTO as the apex body. The reason I've written 5 times NOTO in middle is because these are 5 ROTOs, which are regional organizations that directly report to NOTO.
First slide is on the screen. Is it okay, or you have to change the slide?
No, I have changed it.
No,
Also, it has not gone into presentation mode. Like it is still viewable as an ineditable mode, edited mode. Yeah, it's not gone into presentation mode.
Has it gone?
The second slide has come, but is it okay?
No, it still hasn't gone into presentation mode. I don't know.
Yeah, give me a second. Yeah.
Can we please stay on mute when I'm putting the device on mute? Thank you. Yes, now it's perfect. Please go ahead.
Yeah. So what can be donated is something I just briefed, that any organ or a structured tissue. So hand is not an organ, hand is a composition of structured tissues. And that if wholly removed from the body, they cannot regrow. This is the baseline definition for anything that can be donated. And it can only be donated for therapeutic purposes. We have had a fantastic journey with NOTO. It has evolved to have 5 regional organizations that report into NOTO. As of today, India has 14 state organ and tissue transplant organizations and one regional SOTO, which is for Chandigarh, which are further governed by zonal transplant coordination committees in Maharashtra. I'm just setting up the context. I am given to understand that this is well versed to the entire audience. So how does the organ transplant happen in a registered center? So in a registered center, so basically, if I have to group all the hospitals in India today from an organ transplant perspective, I would group them into three buckets. Either a hospital is a registered transplant center, which means it's a registered center for retrieval of organs as well as to transplant organ, or else a hospital is a non-transplant organ retrieval center, NTORC. Or else it's an unregistered hospital that can neither be a NTOC nor be a transplant center. In a registered transplant center, largely organ transplants are of two types. Recipients either come from a living donor or a deceased donor transplant. In living donor transplants, as far as donors are concerned, medical and psychological fitness is a primary responsibility of the registered transplant center. While in deceased donor transplant, certification of brainstem death becomes a very important step. Then further, we can categorize living donor as near related, not near related. There are legal definitions of this, which I would be happy to put it up if anyone is not aware of that. However, and certification of brainstem death. So there's two ways, right? In a registered transplant center, my hospital is a registered transplant center. So either I have a patient who is an in-house donor where I need to certify the brainstem death, or there's a donor in some other hospital in Mumbai, in India, where a donor is there and I have been allocated an organ for one of my patients. Certification of brainstem death becomes a very critical step. Highlighted in gray because that is something we will discuss for some time going forward. And then we will come back to living donor transplants and just setting the context as what exactly is the role of such tertiary care hospitals like us. So tertiary care hospitals like us are a registered center for brainstem death. Certification of death on account of permanent and irreversible cessation of all functions of the brainstem. In the Act, there's a form number 8. This form number 8 specifies the investigations as well as the clinical tests that need to be performed. These two medical examinations are to be done by a brainstem death committee. These two tests have to be separated at a minimum interval of 6 hours. In a routine day-to-day language, we call these as apnea tests. We call it as a first apnea and a second apnea, and in between there has to be a gap of 6 hours. These medical examinations need to be conducted by a committee. This brainstem death committee needs to be approved by the appropriate authority of every particular state that has adopted the Act. This sentence is very important because health is a state subject. I'm sure everyone is aware. Regulations set by the center need to be adopted by a particular state. If a particular state does not adopt a said Act, it needs to go back to the center and needs to make amendments as to what exactly is it that it wants to change when it is adopting the Act. Thus, it needs to be approved by the appropriate authority of every state. This committee consists of key 4 people: a registered medical practitioner who is in charge of the hospital. The first step is it can either be a medical director, or it can be a medical superintendent, or it can be the chief executive officer of the hospital in case he is a registered medical practitioner. The second is a registered medical practitioner can be any physician, surgeon, or intensivist who is working in the hospital as a full-time doctor. The third is a neurologist or a neurosurgeon. And the fourth is a registered medical practitioner treating the patient. I would like to elaborate slightly on point number 4, which is RMP treating the patient. This RMP need not be the doctor under which the patient is admitted. It can be the critical care doctor who is seeing the patient every day for the last 1 week, 10 days, 24 hours, whatever it is. Or it can be a doctor who is treating the patient. This committee needs to certify the 2 medical examinations that I've stated above in the slide at a minimum interval of 6 hours, after which a particular donor is certified as brainstem death and we can proceed with donation. The allocation of organs after certification of brainstem death is taken up by the local zonal transplant coordination committee, ZTCC. ZTCC passes on the information to all the registered transplant centers in its geography. Later on, in case there is no hospital who is willing to accept an organ, it escalates and sends the alert to respective other ZTCCs. For example, we have a ZTCC Pune, we have a ZTCC Nagpur, and we have a ZTCC Aurangabad. These three ZTCCs are zonal ZTCCs who get involved. If not, then it gets escalated to the state, then to ROTO, and then to NOTO. Once the alert goes to NOTO, it is actually open for all international patients. So a law is very clear. Till the time every citizen of this country denies that particular organ, that is the only moment we can go ahead and offer that particular organ to any international patient who is waitlisted in our country. So with this context, I would want to come back to the main muscle of the discussion, and that is for tertiary care or a corporate hospital in organ donation. I have tried to bucket the entire role of a hospital into these 6 categories. Awareness is one, and I'm going to talk about awareness into multiple categories because it is not just awareness in the general audience, it is awareness amongst doctors, it is awareness amongst administrators, etc. We'll come to that. Brainstem death counseling to a particular donor family is a very critical role that a hospital plays. Parenting and NTalk, I think this is somewhere where Maharashtra is working very aggressively. We've had 3 to 4 rounds of discussions with our health minister, the appropriate authorities, director of health services, etc., as to how does a corporate hospital or a tertiary care hospital be a parent to a non-transplant organ retrieval center. It's hospitals' very, very crucial responsibility to ensure that we do not waste organs. Any organ which has been generated needs to reach the suitable recipient in the shortest amount of time, and that translates into really heavy logistic coordination, where we usually book a charter, we go into the city, our end-to-end time. I have been a part of a heart transplant where we have brought in a heart end-to-end from Delhi, from the OR operating room of a Delhi's hospital to an operating room of Mumbai's hospital in about 1 hour 55 minutes. So those kind of logistics at the middle of the night, a particular hospital needs to be equipped to get that going. And post-transplant care becomes extremely important to take care of your post-transplant patients. On awareness, I'm going to touch upon these 3 categories where for general audience, safety of organ donation is something which is of key concern to a lot of prospective donors. This is especially important in a living donor transplant, where it's a liver or a kidney. These 2 largely are living donor transplants, which is possible. Again, pancreas, hand, bone, those kind of transplants cannot be done using living donors. Wherever living donor transplant is possible, we have a risk ratio. This 1 in 1,000 is the risk ratio in India. This is risk to life. The translation is for every 1,000 living donors that happen in India, about 1 donor dies. I am sure all the well-read audience here would have heard about the incidents at Sahyadri Hospital in Pune. This was one of the rare incidences of a donor death. So safety of organ donation is something that needs to be taken up for awareness. Quality of life post-organ donation becomes important. If I am donating a part of my body today, what would be my quality of life? How does it get affected? Does it affect their lives? And need of organ donation to get a pledge. This is extremely important for a deceased donor transplant. So the first 2 points categorize for living donors. The last point categorizes for a deceased donor. For example, Maharashtra has a very, very good platform for all of us to enroll into organ donation, and it translates into our driving license. On a driving license, it is written that this person is pledged for organ donation in case any of us face a tragic death due to a road traffic accident, which is one of the top causes for a brainstem death. That's the reason for Maharashtra government to take in to all the RTOs. We can pledge through a driving license. So in that case, it becomes a sure shot document that before our death, we have pledged for organ donation. These kind of awareness drives as a corporate hospital, we always do. We have done about 4 large-scale organ donation awareness activities. We have done one at Marine Drive. We have done one at Juhu Beach, where we can target a lot of people to get a pledge. The second step of awareness is with respect to doctors. We need to refer patients to higher centers in time. This is especially true. I am myself a doctor. I studied in one of the peripheral areas of Maharashtra. I did my MBBS from Karad. So we need to refer patients who need an organ transplant to a higher center right in time. If we lose time, then it becomes very difficult for the patient to become reversible. Awareness for doctor-owned hospitals. This is especially important for any hospital. I'm a doctor. If I own a 30-bedded, 40-bed, 50-bedded hospital, I am been a promoter of that hospital. Usually, I have reluctance to convert it into a non-transplant organ retrieval center, which means if I get a brainstem death patient, I can certify brainstem death at my hospital, and the donation can be taken over by ZTCC. This NTORC conversion is very, very poor in Maharashtra. It is even poor in other states. Two states that have very good conversion for NTORC is Gujarat and Tamil Nadu. Apart from Gujarat and Tamil Nadu, NTORCs are not so spread across the country. Maharashtra remains on fourth. And this myth-busting sessions with higher centers as to how does compliance work, how do you take it to the government and get approvals at the right time. Awareness also needs to happen for administrators where you handhold for compliance and, as I mentioned, very complex logistics that need to be put in and need to be executed in time. I would like to elaborate on logistics here. I think the discussion becomes lively if I actually give examples of organ donation that I have myself experienced. This year in the month of April, we had a bowel transplant. We did a deceased donor bowel transplant. The intestine was in Fortis Shalimar Bagh in Delhi, and our patient was at Nanavati Mines Hospital. Given the very good connectivity between Delhi and Mumbai, with at roughly about every 25 to 35 minutes, you have a flight, commercial flight, Indigo, Air India, etc., that travels between the two. We got a call at night 1:45 a.m. for an intestine. At morning 9:30, the intestine was in our OR with the surgery going on. So our cross clamp time, which is the time from removal of organ from Shalimar Bagh's operation theater to our hospital, was roughly around 3.5 hours, which included using the commercial flight, given the expenses of a charter flight at that moment. So these kind of complex logistics, hospitals like us, corporate hospitals or tertiary care hospitals who have the bandwidth as well as the experience in executing it, can be given to smaller centers to develop organ donation in these areas. This is very important, which is donor counseling in BSD. I would just navigate quickly. We have 6 buckets discussed, so this happens to be the second most important bucket. Promoting the cause. This is one of the shots of my hospital where we had a in-house brainstem death donor. A very young guy lost life in a road traffic accident. And we actually gave a guard of honor of about 150 people. Law does not mandate us to do this, but this is a noble cause. He helped 6 people get a life and through the brainstem death. So promoting the cause, giving guard of honors and various other facilities, in case any family consents for organ donation in those difficult times where you're losing someone due to a brainstem death, we provide all facilities which includes end-to-end ambulance services up to your home, shifting the patient, as well as felicitating them in annual event of our hospital. Mumbai does a very good function. ZTCC Mumbai organizes an annual event where last year we had 156 donors in Bombay, where all the donor families were called at Sion Hospital and they were given entire memento, as well as they had an opportunity to talk about their experience. We need a dedicated transplant coordinator to guide the family in grief and post-consent expenses. There are definitely a lot of donor maintenance charges if a particular family consents to do organ donation. Each organ team, when I say each organ team, it means liver team, kidney team, heart, lung, each and every organ specific team have to process very expensive investigations. To process all of those, expenses are borne by ZTCC up to specified limits, borne by hospital up to specified limits, and beyond that they are charged to a recipient who is going to get the organ, but no expense goes to the donor family. This again is something that awareness regarding all of this is kind of poor in and around our community. Coming to NTORC, this is a very, very important slide. What the hub so hub and spoke model is, I mean, it's very, very primitive. It's probably been there for more than centuries together in multiple businesses. Application of this very simple model in organ transplant is key. Each and every corporate hospital can be a hub, and every NTORC can be a spoke. You can take it one step further, and I'll give you an example of that. Let's say Nanavati Max Hospital is a hub, and I have Hospital A, which is a non-transplant organ retrieval center. So my team hands-hold them. We become a parent for them, and we help them in compliance. We help them in BSD committee. We help them in clinical assessments, and they can certify a patient as brainstem death, and the organs can be retrieved. And as per the waiting list and criteria of the government, they can be allotted to various patients. How do we take this one step forward? In this scenario that I just mentioned, Hospital A is already a registered non-transplant organ retrieval center. So, but what if it's a hospital that is not registered at all? Let's say it's a hospital B in any of the western suburbs, and they have suspected that a particular patient has brainstem death. This year, between Jan to August, we have had 3 such cases where we got a call from a hospital which is not an organ retrieval center, neither a registered center for transplant. So our team went there, we counseled the family, and we evaluated the patient. We cannot perform a test. I repeat, we cannot perform a test in that particular hospital. We can only clinically evaluate and suspect. However, on suspecting that, we can transfer the patient to our hospital. So my team of intensivists, my team of consultants from internal medicine and neurosurgery, everybody went to that particular hospital. We shifted the patient to our hospital at 0 cost. And after following the entire process, then certifying brainstem death, the tests did come as brainstem death, and then organ transplant happened. Thus, every hospital needs to be a hub and needs to develop strong spokes. ZTCC has taken up this role over the last couple of years, where any hospital can call the helpline of ZTCC saying that we suspect that there's a brainstem death in our hospital, and ZTCC will direct the nearest corporate or a tertiary care hospital to go to that hospital, see the patient, and do the necessary. We can also support BSD committee. I would just come back to that slide where I said we need 4 members to certify any particular patient as a brainstem death patient. For criteria number 3, which is having an in-house full-time neurologist or a neurosurgeon, might not be true in multiple hospitals. In this, what the rules allow, as well as we can play a role, is we can be a joint name for criteria number 3, which means my neurosurgeon or neurologist can go to that hospital for a BSD committee and certify both tests as brainstem. Thus, I say parenting smaller hospitals is a key role and responsibility for tertiary care hospitals to promote organ donation. So how does organ transplant happen in a registered center? When I say a registered transplant center, now I am just moving from deceased donor to living donor. And in the interest of time, I'm going to keep it very crisp and would open it for Q&A. So in a registered transplant center, now we are discussing living donor transplants. We discussed deceased donor transplants in some detail. In living donor transplants, medical and psychological fitness of a patient becomes extremely important and remains the responsibility of the respective clinicians. These transplants can happen in 2 categories. They are either near related or they are not near related. Please note, there is no mention of unrelated transplants in the Act. It is either near related or not near related. Near related transplants are same lineage. For example, mother, father, grandmother, grandfather, siblings, and grandson. So that entire lineage comes under near related. There's a special clause for spousal transplant, and then there are not near related. Any cousin, first degree, second degree cousin, aunt to nephew, niece, uncle, those kind of transplants come under not near related. Both the transplants are legal in India. Largely these happen in liver and kidney. Every hospital, so as a hospital, I can certify near related transplants from a committee called competent authority. The law has a definition of competent authority. A competent authority for any hospital is either the head of the institution or a committee constituted by the head of the institution. For example, my hospital, we have a head of the institution. The head of the institution has constituted a committee of 8 members, minimum quorum being 4. And with that 4 quorum, we go ahead as competent authority and we decide whether this transplant can go ahead or not. What do we look for? A case comes to me, let's say it's a mother to son transplant, an example, and it's a kidney transplant. So I need documentary evidence to prove the relationship. Any patient coming to me and saying, I am the son, she's the mother, and we need to undergo a transplant. I need to prove the relationship using documentary evidence. This is done through two methods. One of the methods is a DNA analysis, which we do mandate and we get it done for all our cases. In any emergency case scenario, because DNA analysis takes about 4 to 5 days, we can make an exception and we go ahead. So that is one documentary evidence to prove the relationship. The second documentary evidence is entire documentation, whether it is your school living certificate, your birth certificate, your PAN, Aadhaar. Those have to have the names, same, exactly matching to each other. And basis that, documentary evidence is established. The second thing to establish is this donation has to happen out of love and affection. You cannot force anyone to donate any part of their body to any patient, irrespective of the condition of the patient. I repeat again, irrespective of the condition of the patient, you cannot force any donor to undergo donation. Thus, the basis of relationship to develop love and affection. For example, if I am married to my wife is donating a part of her liver to me, I need to provide documentary evidences of me staying with my wife for the last 15 years. It has to be a marriage certificate, needs to be a photograph of our marriage, any trip that we took, a birthday that we celebrated. There have to be moments of ups and downs that all of us go through in our lives, and this has to be the basis to develop love and affection. This is also established when we take one-on-one interviews on camera as a part of the process. Third is also a very important point, that there has to be an evidence of income status and no monetary transaction, which means that between the donor and the recipient, the income status needs to be same. We cannot have gross disparity. I cannot have someone having a ITR filed for 1 CR and who is a recipient and a donor filing ITR of 1 lakh, 2 lakh, or even not filing an ITR. We cannot have gross differences in income status. This is and can be a justified reason for rejecting the organ transplant. So evidence of income status and no monetary transaction needs to be established. So we take bank statements, etc. Again, this comes from the Act. And this is the final point is very interesting. And the final point is that what if there's an absence of linkage? For example, it's a aunt to a nephew transplant, and there's the linkage is absent. The real sister has expired, or the grandparents have expired, so we cannot prove the linkage using DNA. The technology and the molecular analysis today has gone so good. So if it's a entire female lineage that we are talking about, which means grandmother, 2 sisters, and one of the sisters, a daughter, is the recipient, the other sister is a donor, then we can establish lineages of females. The mitochondrial DNA is exactly the same. That's the unique identity in all the females. And in all the males, if its entire lineage becomes male, then we can establish using the sex chromosomes. So sex chromosome is going to be unique in that particular lineage, and we can establish the linkage. So even in absence of linkage, we have done about 10 to 15 transplants where we have established relationships using maternal or paternal transplants. So spreading awareness about all this, actually establishing these kind of protocols in other hospitals is a large responsibility that a hospital like ours and the scale of our hospital needs to do. So that's a brief on organ transplant from my end. I open it for Q&A, and I hope you have found it useful.
Okay. Thank you very much, Dr. Mehta, for giving very elaborate information about organ donation, and especially the role of corporate hospitals in organ donation. You are talking about entry ORC. Now, you say that your hospital, the corporate hospital, can be a hub, and the others are from where they can take those who are not even registered. You can take the organs. The patients can come to your hospital. That is only possible in the same city. I'm talking of, if you are talking of Mumbai, so you know that place called Dhanu or Shirdi or Nasik, where say Dhanu, there is no hospital which is registered under for organ transplant. Don't you think that from there no one would like to send the patient who is going to be the brain dead, declared to be the brain dead, and will come to Mumbai, give their organs, and then take the body back for the cremation. Instead of that, which I am nowadays advocating, and I have a lot of meetings with your doctors and marketing team, why not have a mobile organ retrieval center? Because you rightly said that the hub is yours. It means the licensing part or all the government certifications belongs to you and your doctors and your team. Similarly, that mobile retrieval, organ retrieval center means that the operation theater, which is mounted on a vehicle, will be of yours. The licensing for that operation theaters is yours. The team will be yours. That will be more beneficial to get, because 85% of the district headquarters in India doesn't have a retrieval center. Only 15% cities or the district headquarters we have. Do you think that it is a viable or feasible proposition?
So there are three ways to look at it. One is if a patient is clinically non-transferable, that becomes a challenge, and which is what you are trying to highlight. If a patient is clinically transferable, I think we have done distances from Surat to Mumbai, and that was just an example. If a patient is clinically non-transferable, then we need to create a scenario where we can retrieve organ as well as organ donation can happen in that particular center, which is not registered. I agree to that. However, having a mobile center becomes a challenge. I'll tell you reasons why. Any brainstem death donor is going to be clinically so complex. And when I say the patient is non-transferable, it means patient is ventilated. Patient has at least 3 to 4 supports, about 7 to 8 syringe pumps ongoing, 2 to 3 infusion pumps ongoing. You cannot create a scenario where you can easily retrieve the organs. I think that is where I think actually ZTCC Mumbai is working on actually relaxing the guidelines to enroll hospitals as NTORCs. Today, the guidelines for any hospital to become an NTORC, you have a very wide list of things: a well-equipped ICU, a full-time intensivist, a team of doctors, etc. If we can relook at those guidelines, which is actually happening today, then I think we can have more and more NTORCs. As you said, that's the best solution. The alternative solution that you propose is doable only in less complex cases. But I'm afraid if a case is less complex, it can be shifted to either of the hubs. If it is not shiftable, non-transferable, then it is so complex that a mobile center won't help.
Dr. Mehta, I disagree. Only one point is the patient can be shifted clinically. You can shift, but is it possible to shift a person when the patient relative knows that this patient will go to Mumbai just to donate the organs and then body has to come back? I don't think today even Mumbai people are not donating organs. So much reservations are there. How you can convince somebody? Because Mumbai hubs, you have or you can shift from any other hospital, but shifting from a outside is a very, very challenging thing. Anyway, thank you very much. Now I am opening for the questions to be asked. I actually want the first question to go to Dr. Rohan Monis. If you are there, Dr. Rohan Monis, please unmute and switch on your video if you are available, because you yourself is a doctor as well as a administrator of a medical college and hospital in Mangalore. Are you there, Dr. Monis?
Hello, sir. Hello, sir. Sir, can you hear me?
We can't see you.
Yes, 1 minute. I'm outside, so still 1 minute.
We can hear you.
But we can only hear you. Yes, now we can
really
see you. Yes, please.
Dr. Pushkar, thank you so much for that presentation. Very beautiful, especially for the administrators and for the doctors. It was very to the point, discreet, and on an awareness ground. I'll give you like a 10 on 10 on that. But just the other factor is for a non-transplant healthcare center, I think we can also, if we don't have a neurologist or a neurosurgeon, can we use a combination of medicine and anesthesia or medicine and surgery to declare brain dead? Is that possibility also there? Because in the peripheries, we have lack of specialists. That is primarily a case. And remote telemedicine is not allowed in such cases. So what are your views on that, Dr. Pushkar?
So I think thank you for that question, a very interesting one. So the views are that as of today, that provision does not exist. The provision exists that a neurologist or a neurosurgeon from a registered transplant center can go to a particular NTORC and become a part of the BSD committee. But I think it is worth evaluating if a intensivist especially or an internal medicine specialist can take up that role.
Okay.
Yeah, because of late, I think when they had the critical care medicine conference, I think the Indian Society of Organ Transplantation has been very, very apt and very rightfully giving them the honor or the power also of declaring brain dead, the intensivists, so that
Absolutely,
we
yes.
increase the number of transplants in the country primarily.
Absolutely, you're bang on. That's the reason in the BSD committee criteria at the end I mentioned a registered medical practitioner treating the patient, but need not be the primary consultant under whom the patient is admitted. That is exactly a very critical role intensivists are playing today.
Okay.
Thank you so much, Dr.
Thank you, Dr. Monis.
Thank you.
Before I will go to the next question, my question, one more thing you have mentioned about unrelated word. You emphasize that unrelated is not allowed. Distant related is allowed. But there are many instances where the unrelated persons have given their kidneys and liver, like Arun Jaitley ji or Sushma Swaraj ji, they are unrelated. So there is a provision in India in the NOTO that unrelated can also donate, subject to out of love and affection. For that, the screening committee has to screen.
Yes.
Is it correct, Dr. Mehta?
So the screening committee can screen, yes, but you need a code or an order from the High Court for that to happen.
Dr. Mehta, what my understanding says, you have to check. I will also check that the screening committee decision is final, but in case if there is a delay or if then only the court can interfere, because there is a case in last February when the Delhi High Court has to intervene, but they asked the screening committee to decide in 3 months' time. But they cannot, the court cannot act as a screening committee. That ultimate power is with the screening committee only.
Yes.
Okay.
So for unrelated and not near related cases, hospital's committee only recommends a particular case. In an unrelated case, the hospital screening committee either recommends the transplant or does not recommend, depending on the screening criteria. Let's say that in a completely unrelated case, I am satisfied as a committee member and I am recommending that this transplant can go through. There's love and affection, enough evidence. Let's say two friends are staying in the same home for 40 years and there's enough love and affection. There's a strong relationship between the two of them. I refer it to my district authorization committee. The district authorization committee is the final decision-making body. I do agree to that. In many unrelated cases, what we have seen is the district authorization committee, and this is basis experience, refers the case to the court. And then the court comes back saying that the evidences, so a screening of evidences happens from the court's end, and then the decision comes back to the authorization to give that decision.
But I know very well that neither in Arun Jaitley's case or Sushma Swaraj's case, they have gone to the court. It has been directly by the screening committee only, which is a government committee, not a allowed
it's a government
hospital. Okay.
Yeah.
Okay. Yes. So whosoever wants, yes, the Professor Dr. Sudhir Saran, please. Professor Dr. Sudhir Saran.
Thank you, Dr. Mehta, for a very educative presentation. It shed light on many aspects which I was in gray area. So thanks for that. You mentioned that it will further the cause of donation and transplantation if there is encouragement to the donor family, like giving them honors and recognition. Now, my concern is where I want you to shed more light on is where does it stop from the white to gray or dark area? Like where will it become bribing the family? Those issues. Please continue.
For a brainstem death to occur, irreversible damage has to happen to the brainstem. It can only happen in a very severe case of trauma where I am impacted directly on the brainstem. It cannot act as a bribery where I am bribing someone to become dead and now generating organs out of them. That is not the case. So in this case, when anyways the family, so one of the bigger steps in brainstem death is we all understand cardiac deaths, a patient dying out of cardiac death. In brainstem death, the first step to counsel the family that accept this is also one part of death and this is also a type of death. Thus, they need to accept that. And then is the further incentivization to say that you have taken the right decision. So this guard of honor and everything is to promote that you have taken the right decision. Don't go back home, don't go back to the society thinking that you have not taken the right decision. I understand your black and gray part, but it's very, very difficult to do that in brainstem death. Rather, in my personal view, it is impossible.
Okay, thank
In
you.
living
Thank
donors, I agree. In living donors, I completely agree. In living donors, it's a separate conversation, and it can be a very detailed conversation at that. But
Yes.
brainstem death, no.
Now,
Thank you.
whoever wants to ask the question, please unmute yourself and raise the hand or unmute so that immediately I will take whosoever wants to ask the question. Okay, I will again, I am coming back to you, doctor. As a corporate hospital, as you said, you are doing so many things. What challenges you are facing in organ donation?
Thank you for asking this question. Very few people ask that. I think so. I'm going to be very upfront about it. One of the biggest challenges all of us face, and I have been attached with 3 top hospitals in Mumbai over the last 3 decades, and the challenge has been the same, and that is logistics. Right? No corporate hospital. I'm a doctor. I have pursued management studies. I do not have the number of the air ambulance services in the country, the charter flight. I don't have a track of which flight is where, because it's not used for these purposes. So logistics is one area where corporate hospitals face a lot of challenge. We have over a period of so many years and experience developed those connects. But that is a challenge which can be looked into from the government, especially because of the cost also. In the Delhi to Bombay heart transplant that I mentioned, we ended up spending 7.8 lakh rupees from patient's pocket, and that was 3 years back. So that's a lot of money for any patient to pay apart from the transplant cost. So it's not just a cost, plus the companies bill us giving the emergent situation that we are in, the time crunch situation that we are in. So all this plays a key role, and logistics remains a key challenge.
Okay, so basically the logistic is the challenge which corporate hospital faces. What about the bureaucratic or the government delays or red tapeism or the permissions which you require immediately because you have to take the authorization sometime?
Yeah.
Is there any that challenge also there?
So to get a particular license for a particular organ, once we get a license, it's valid for 5 years, and I think that's a good enough time frame to get it for 5 years. Had it been a couple of years or 1 year, I would have cribbed about it. But in 5 years, a lot of things change in the industry as well as in the hospital. So on the licensing front, I think it's a pretty smooth way of doing the license. Plus, the license also has criteria to screen your OTs, to screen your instruments, to check availability of all of that. And I think which is very, very important. We cannot be in a situation where we give licenses and then later on say that this center is not equipped to handle the patient. That would be injustice to everybody.
Okay. Now, doctor, the main thing which is coming about the poor patients. Is your hospital or the corporate hospitals, because there is a myth, the people says that the corporate hospital means that we have to shell out lots of money. But what about those who are PPL? What facilities the corporate hospitals are giving to them? Or what facilities you are getting from the government?
So not from the government for sure, but definitely from a lot of trusts. I would say 65% of my pediatric liver transplants today are funded transplants. If you would see pediatric liver transplants are needed in kids who suffer from Budd-Chiari syndrome and diseases like that. And those diseases are often seen in a lower socioeconomic group, and they are well documented in the medical literature. So a lot of help comes from very, very good organizations, including the Tata Trusts, etc. Hospital, we have a help desk for funded transplants. Any patient can approach the help desk, whether it's a bone marrow transplant, a liver transplant, a kidney transplant. We ourselves initiate applications on behalf of the patient to multiple trusts. Once that approval comes and we go ahead with the transplant, and the trusts settle with us over after 90 days or 120 days. So there's another thing which has come up very well right now, and these days, that is crowdfunding. I think that also makes, whether it is other platforms without naming them that provide crowdfunding, it serves as a good platform for patients to raise funds. And hospitals like us then reduce the price of the transplants. And for pediatric transplants, I always end up giving 1.5 to 2 lakh rupees less price, and I just whatever cost of medications, consumables, etc. is required by the hospital to perform the transplant then gets recovered from the patient.
But doctor, there is a PMJY, Ayushman Bharat PMJY scheme, in which the organ transplant comes for the BPL up to 15 lakhs the government is funding. Have you approached any time there?
So our hospital is not empaneled in this scheme.
Because
However, our hospital is empaneled in CGHS, and we
because
have done liver
if
transplant.
you will get that done, because the advantage is that 15 lakhs, although I met many doctors and as well as the government officials, they are not agreeing for that. But two proofs are there. The first was that Minister of State Health on 8th of December 2023, in a written reply to in a Lok Sabha, mentioned that this now we are providing 15 lakhs for all types of organ transplants under that scheme. And recently, on 2nd of August 2025, when this organ donation, Indian Organ Donation Day was celebrated in Delhi, organized by Ministry of Health and Family Welfare and NOTO, our Health Minister, Mr. JP Nadda, has given a speech, and in that it clearly says that the up to 15 lakhs under the PMJ Ayushman Bharat PMJY scheme is there. Why the corporate hospital is not taking that scheme, so that BPL patient need not to pay anything, or you need not to go to any trust for the kidney as well as for the liver transplant. What do you say about that, Dr. Mehta?
So PMJY as a scheme is a central scheme which is adopted by states. Again, I keep coming back to the fact that health remains a state subject. Now, in case of Maharashtra, it is an integrated scheme with MJPJY, right? So it's an integrated scheme. Plus, the implementation of the scheme happens in three models. There's a insurance model, there's a assurance model, and there's a assurance model. So all these dynamics come into play, whether and can you selectively enroll for a transplant and not enroll for other services offered under PMJY. So depending on all these dynamics, I think corporate hospitals take a call whether to empanel or not to empanel. We have been a registered empaneled center under CGHS. We have done liver transplants. We do actually liver transplants under CGHS scheme. But we are not an empaneled center for PMJY.
So that is the reason the poor patients are not getting the free treatment for transplant, and that is a very big issue, because if the corporate hospitals will take up this matter collectively and take the registration only for organ transplant, because only for organ transplant this limit is 15 lakhs, otherwise limit is 5 lakhs in Ayushman Bharat scheme. This is the only one, and anyway, this I will be sending you the bulletin which our club is publishing every week. This week, I have written an article and I will send to you. Please go through it, and I will try to meet you in person. See to it that we must get, because our members feel that we are not doing project, but this is a very, very important project. If we will enroll, get the corporate hospitals enrolled for PMJY scheme, so the poor patients will get the organs. Otherwise, there is no chance for them to survive. Okay. Thank you very much. Anyone else wants to ask any question? Rotarian Deepansha, I know that you are not at home, either driving a car or I don't know, you are moving. Are you at home or where are you?
Yes, in fact, I'm driving, just coming out from the Costco. But anyway, thank you so much, Dr. Mehta. It's a wonderful presentation. Only thing is how, looking to your expertise in this area, wonderful, web of this complexity. What is your opinion on how we can improve, right, all this system to simplify, like the system we have in the USA? What is your opinion, or what is your team or Nanavati Hospital or Expedis hospitals are doing for these things to help out the common people, community people, and poor people? Thank you.
So, two aspects to your question. One is how do we simplify the system? I think as corporate hospitals would be a responsibility to train a lot more people. There's no formal course in organ transplant. There's no formal education that you can offer in all this. That plays a key role. And as I said, for poor patients, I am actually very proud to say 65% of my transplants are funded transplant. The patient does not pay a single penny from his own pocket.
Yeah, hopefully we're looking forward to this. More people get the opportunity. Thank you so much.
Thank you very much. Anyone else wants to ask the question, or shall I over? Okay, over to you, the secretary, Inspire Secretary, Rotarian Ruby Agrawal.
Actually, me, right?
Thank you so much, Dr. Mehta, for your wonderful presentation and very detailed question and answers. And I request Dr. Rohan Mohanis to please give the vote of thanks.
Hi, good evening, everybody. Sorry, my video is off. I'm on a travel mode right now. Dr. Pushkar, amazing presentation. The point of enlightenment is for our team, because our team is a cohort of seniors, youngsters, doctors, non-doctors, lawyers, donors, recipients, and also we are open on YouTube. And this has become a very, very strong message in terms of understanding across all levels. I thank Rotarian Ritika and Rotarian Ruby for conducting this beautiful session. I also want to thank our charter president, Rotarian Lal Goel ji, for having Dr. Pushkar on our panel, and I think we can even push in for more ideas from him. Dr. Pushkar, I wish you and your team an amazing success, and may you beat all records in the state of Maharashtra. God bless you all.
Thank you.
Thank you so much.
Thank you so much. I unmute yourself, President, and adjourn the meeting, please.
The meeting is thereby adjourned.